I have not been quite promoted to Vice-Chancellor of the University of Western Australia, and I have no intention, but I'm absolutely delighted to be here because it's much better being involved with diagnostic haematology and working with you on the myeloproliferative neoplasms than running a faculty, let alone a university. So it's a pleasure, and I'd like to thank all of the organisers for inviting me. And I was a little bit rude and said, yes, I'd love to come, but I want to give a talk. So now I've got to sing for my supper. So Anne, thank you for accommodating my rudeness. So both David and Kate have sort of dropped me in it by saying Wendy will talk about that, and hence I've been changing slides on the fly. It is, however, the topic that I put up myself, which was looking inside the bone marrow of myeloproliferative neoplasms. Many of the people in the room here, many of you will have had a bone marrow test. Some of you will not. Some of you will have heard the term and not know what it is and wonder whether you should have had one or not. And I suspect there are very few of you who have in fact seen what a bone marrow looks like, although in the last hour you have seen some pictures from both David and Kate. So there is not going to be a test at the end, but I hope by the end you will have learned a little bit about what the bone marrow looks like in health and in myeloproliferative neoplasms. I don't need to go through this because Kate has, and she's used the very term that I use, that the bone marrow is the blood factory. It is where our blood cells are made. And when we have a bone marrow test done, there are in fact two types of test. The bone marrow aspirate, where the sample of the bone marrow is sucked out, if I can use that term, using a needle and a syringe. And the trephine, or a biopsy or core biopsy, where a specimen, a piece of the bone marrow is removed, a little like removing the core from an apple, as Kate mentioned. And today I'm going to show you slides, images of what we see down the microscope with both of those, because there can be confusion. There are two different tests, but they are taken from the same site. And taken from that site there, as you can see, where the star is the posterior superior iliac crest. And the reason we take the sample from there is the bone marrow is thick enough that we're not going to punch the needle all the way through to the other side and hit some crucial organ in the body and have a bit of a bloody fountain on the ceiling. In addition, well, we could do it from here, our sternum, our breastbone, but that bone is very thin, and if the needle were to slip and go through the other side, you know what's there? You can do your anatomy class later. The other reason we do it from the posterior superior iliac crest is that in people like myself with a little more fat on my bottom, here, when you curl up into a ball in the fetal position, you can all do it, stand and do it, the bone is quite close to the skin, and that is the reason. So it's close to the skin, and there's a lot of bone, and we can get a good sample of bone marrow from that site. That's enough yoga for today. So the first test is the aspirate, where we put a syringe on the end of the needle. Once we put the needle into the bone marrow cavity, and we then suck out or aspirate a sample of bone marrow and then put it onto a glass slide. And these two images of what it looks like after we have taken that sample, spread it onto the slide and the image on the left, or put one slide on top of the other and squashed it a little bit and then spread it out, called a squash preparation. And we then take that to the laboratory where it is stained. And I can tell you it is stained because we don't have blue bits in our bone marrow. The blue is the stain, and the red blood cells here are all looking brown. So I don't know if this it does work, but I'm going to use the pointer and I'll try and do left and right. The blue bits here at the top of the slide are the particles or the pieces of bone marrow that have sucked out. And for those people here who've had a bone marrow aspirate done without a sedative at all, you will have felt a very sharp, hot feeling, which is very short and fleeting, and it's the sucking out of those little pieces of the bone marrow that have hurt you. So that is the smear, and in the squash preparation, so I'll do it on this side now, in the squash preparation, those blue bits are again those same bits of bone marrow that have been imprinted onto the glass slide. That's at very low magnification, taken just with a standard camera. There's no microscope that's been involved here. Once we look at the bone marrow, and we look at the bone marrow, my pointer, at the area just behind these blue blobs or around these blue fragments, so again over here, that's where the cells are really beautifully spread out and we can get the precise cell detail. And as I said, there is no test, but it's just to show you what normal bone marrow looks like. And the message is that the cells all look different. There are different cells making white blood cells and red blood cells, and the white blood cells are generally purple, and that's not because we're colourblind, but again because of the stain. So the cells here that you can see on the left are making neutrophils, they're making red blood cells, and the big thing on the right-hand side is the megakaryocyte. The megakaryocyte, you can see, is much, much bigger than the other cells. It is a huge cell, and the platelets that Kate said that I would mention, and now I better, platelets are derived from the megakaryocyte. It is little bits of this edge, the cytoplasm, that are budded off that big megakaryocyte that makes the platelet. And many patients with MPNs have too many platelets in their blood, and generally because there are too many of these megakaryocytes in the bone marrow. So that is normal. Normal bone marrow aspirate. This is now the normal bone marrow Trephine biopsy. This is taking the piece or core of bone marrow. What is an adequate length? Again, just going back, for those of you who have had a bone marrow biopsy, this is generally performed as the second part of the procedure, but not always. Sometimes this is done first. And this is where you might feel a sort of awkward rotation motion. You might feel a little bit of a crunching feeling. Don't anyone faint in the room, please. Although we do have a good few doctors in the front row. But it's a crunching feeling, and the crunching feeling is because in the lower image you can see some little pink strands, which I've called trabecular bone or spongy bone. And it's really the cutting of those, but it's very fine strands that you will then feel, and a slight crunchy feeling. The length of the bone marrow, what is adequate length? It should be 2 centimetres. Anything less than that is generally not enough to be able to assess the sample adequately. And how do we know that we have an adequate length sample when we're doing the test? Well, we know yoga, but at least finger exercises. When we're doing the test, and here is your skin and here is the needle, as it goes through, and I've got my finger positioned at probably 3 centimetres away, and as my finger gets towards the skin, I know that I have enough of the needle inside and I'll have an adequate sample. So that's how we know that we'll get enough sample, and it then goes into a solution where the cells are then preserved. It's then processed, and it's processed into paraffin wax. Sections are cut, very, very thin sections, 3 or 4 microns, and then they're stained. And it's a different stain and therefore different colours from the previous slide. And I'm going to go over time, I feel it already. Yeah. So when we then look at the bone marrow sections, and this is now only looked at magnified twofold, and then with the camera as well, you can see the pattern of normal bone marrow. We have the outer bone that's indicated there, which is the bit that's closest to the skin. And then the bone marrow behind it with those pink lines, which I've called, as I said, the trabecular bone. The white spaces that David mentioned earlier, which is the fat, which the amount of fat increases with age. And then the purpley stuff in between the bone and the fat is where the cellular production, the blood production is happening, the word being hemopoiesis, blood cell production. That is all normal. At higher magnification, this is what the biopsy, the bone marrow biopsy, looks like. Again, the fat space is in white, the active bone marrow in pink and purple. And on the right-hand side, in higher magnification, the megakaryocyte that I mentioned earlier from the aspirate, you can now see is being much, much larger than the other cells in the bone marrow. I'm making a point about the megakaryocyte because when we look at the bone marrows of patients with MPNs, it's the megakaryocyte that is the most abnormal cell. The other cells are increased in number, but the megakaryocyte looks even more abnormal than you might think here. It's a strange-looking cell which looks really abnormal in MPN. So not every patient has, with an MPN or being diagnosed with a possible MPN, has a bone marrow biopsy. I think everybody with a suspected diagnosis of MPN should or even must have a bone marrow test. Now, some of you who are in the room who have not had a bone marrow test will say, oh dear, I haven't been managed properly, I should have had one. I'm very much the person who always says you should have a bone marrow test at the time you are diagnosed, because we really need to know what the disease looks like at the time you first present, so that when you do have treatment, if your symptoms do change, if there's a plan to change your therapy, we know what the baseline is. We know what the disease looked like at the beginning, and then we can see whether, in fact, there has been any change. Anything that's worrisome or anything that's really, really good, showing, in fact, it looks like normal bone marrow now. So I think it should be performed. Somebody with an abnormal blood count suspected of having a myeloproliferative neoplasm, it confirms the diagnosis and tells you the precise subtype, because by the end of this talk, you'll be able to distinguish between the different types yourself by looking at bone marrow. Okay, enough. Kate has already mentioned the complexity of what happens in normal bone marrow and the blood cell production. I'm not going to go through that, but I do just want to briefly mention in one slide with words and then lots of slides with pictures about the bone marrow pathology, how the bone marrow looks different in MPN from normal. Firstly, as both David and Kate have said, the bone marrow is in auto-drive in MPN. It doesn't have its normal controls, so we have the right numbers of cells and fat. As a result, too many cells are being made in the bone marrow, and the Greek word that we use for that is increased cellular, hypercellular. The appearances of the bone marrow differ in each of the MPN entities, as I'll show you. The megakaryocyte is really the most useful cell for determining the subtype, because they do vary in morphology between the diseases. Scar tissue, or reticulin, forms in the marrow as the disease progresses towards myelofibrosis. So scarring, it's like there's an internal scaffolding that's formed in the bone marrow inappropriately, which is then stopping blood cells from being formed at all, which I will show you, and that is a feature as the disease goes to myelofibrosis. In addition to that, the bone can grow, so that thin bit of spongy bone that I showed you, very thin slivers of bone, that can also grow, and you can get new bone formation within the bone marrow itself, which will then reduce the amount of space for blood cell production. And so as well as the scar tissue, there's in fact reduced capacity, reduced space for blood cells to be produced. The fancy term for that is osteomyelosclerosis. Osteo is bone, myelo is the marrow, and sclerosis is the whole process by which the scarring and new bone formation is occurring. So both the aspirate and Trephine biopsy are required in the assessment, and I'll show you why in a moment. Another term that I just put in at the last minute, because I know some of you will have heard, and that is a dry tap. A dry tap is a term used when you do the first part, the aspirate. We try and aspirate, suck out bone marrow from the bone marrow cavity, and nothing comes. And that is generally due to too much reticulin or fibrosis. The scarring has occurred in the bone marrow, and it's precluding the cells from actually being dissociated from the bone marrow site, stopping it from coming into the syringe, and we have a dry tap. There is nothing in the syringe. So that's what that term means. It's not a good sign. It usually means that the bone marrow has scar tissue within it, and in that case we really must do the second test, the biopsy, to get a sample to assess. So these are the diseases that I want to illustrate, but if anyone wants to tell me time is up, I can stop any way through. No, I haven't started, so don't stop me yet. But I'm aware that most people here are interested in Polycythaemia vera, essential thrombocythemia, and myelofibrosis. But if I have time, I would also like to illustrate what the bone marrow looks like in 3 other myeloproliferative neoplasms: chronic myeloid leukemia, chronic eosinophilic leukemia, and systemic mastocytosis. These are also of the myeloproliferative neoplasm family. And I don't know if there are people who know of these diseases in the room, but I would like to get to them if I can. Right, fasten your seatbelts. So we'll start with Polycythemia vera. David explained what it means. Too many red cells in the blood, and we don't know why. And this is the aspirate. In Polycythemia vera, David used the word pan-myelosis. Pan means everything. Myelosis, everything that's produced in the bone marrow, is increased. In other words, in the bone marrow, there are too many cells of every type: red blood cell producing cells, white blood cell producing cells, and too many megakaryocytes. The red blood cell and white blood cell forming cells look normal, and the ratio of how many of one to the other is also normal. There are just too many of them. The only cell that looks abnormal is the megakaryocyte, and it's so a megakaryocyte here in the bone marrow aspirate, another one here, another one here. We don't normally see that many close together. And over in the second picture, there is one megakaryocyte, this one here. And I said all megakaryocytes look strange because they have very unusual biology in how they reproduce themselves. But this one in the right-hand image is even stranger than a normal one. And the word that we use for strange-looking cells, where they resemble one another, but they vary as well, is pleomorphic. Pleo is Greek for many, and morphology is what they look like. So many morphologies, many different shapes and sizes. This is the bone marrow biopsy, or the core of the bone marrow. And if you do David's maths on age and the amount of fat, if this were to be a 75-year-old person, you can see there isn't 75% fat. There are too many cells. It's very difficult to see what the majority of cells are. The only cells that really stand out are, again, the megakaryocytes. And in an image at this magnification, I would expect to see only 1 or maybe 2 megakaryocytes in each of those 2 images. And the one on the right, you can do your own maths, but I get, I think, 4. The one on the left, 1, 2, 3, 4, 5, 6, 7, perhaps 8. And they do vary in morphology. This big megakaryocyte up here has something inside its cytoplasm. Cytoplasm is that pink package. The purple bit in the middle is the nucleus. And here we have another cell that is sitting inside the cytoplasm, inside this megakaryocyte. There's another really strange Greek word for that, and it is emperipolesis. Don't worry about the word, but it's an interesting phenomenon that we see in MPNs, where you can see one normal intact cell, in this case it's a neutrophil that I was pointing to, right inside the cytoplasm of a megakaryocyte. It's not a diagnostic feature of MPN, but is certainly an association. We don't know why they're there, but from a diagnostic point of view, I find it extremely helpful. And I can tell you I recently had the opportunity to look at some mouse bone marrow. They didn't come to a forum like this, but I was looking at these were mouse models of MPN to try and help us in research to learn more about the diseases. And I was asked whether I could look at normal and mouse that had had a genetic change to induce a myeloproliferative neoplasm. And I was 100% correct in distinguishing, determining which was normal and which had the MPN. And that was one of the features I was using to identify the MPN mouse bone marrows. So we use it in mouse models, but more importantly, we use in clinical diagnosis. So that's PV. Too many cells of all types. The megakaryocytes in particular can look, they have great variation, particularly the image on the left, and that feature of other cells in the cytoplasm can be used. Now PV, in fact all the MPNs can progress. We don't want that to happen, and the clinicians in the room will try and work with you, try and stop that happening, or if it is going to happen, identify it as early as possible so something can be done about it. The image on the left is showing what happens when an MPN progresses to an acute leukemia, usually an acute myeloid leukemia. And at the bottom on the left are three of the cells that I've been able to point to, showing that is what the leukemic component looks like. Here is another leukemic cell, and this is another one here. So the amount of normal appearing bone marrow will reduce, and these leukemic cells, also known as blast cells, will appear in the bone marrow, and that's evident of the acute leukemic progression or transformation. On the right is what happens when the disease progresses to myelofibrosis, or the scarring of the bone marrow. And even if, as still amateurs in the room, you can see this is what PV looks like. The slides I've just shown you. And without knowing anything of pathology or microscopy, just looking at art, I think you can see that that image on the right is different. There is this streaming effect of the cells, that's sort of a pattern that we didn't have before. It looks as though there are fewer dark purple blobs, which is the nucleus of the normal producing cells. And the megakaryocytes harder to identify because they look really peculiar, and that's one here, there's one there, a nucleus here, and so on, and they're really packed together very tightly. 5 minutes remaining, right, I'm moving right along. So, okay, so we could have a lunch session as well if you like. So essential thrombocythemia. Too many platelets in the blood and commonly detected on a routine blood test. The platelet count is high and for no particular cause. I'm not going to show you the blood, but in the bone marrow, the main feature is increased numbers of megakaryocytes. The other cells, the red blood cell and white blood cell forming cells, are generally normal. Normal in number, normal morphology. They can be increased a little in patients who have a JAK2 V617F mutation, but otherwise the bone marrow is normal. Any increase in the cellularity of the marrow is because of an increase in the number of megakaryocytes. The second thing is the megakaryocytes have forgotten to stop dividing. They keep on growing, and so some of them are really, really big. It's hard to see that they're really, really big on the aspirate, although as an obsessive-compulsive hematologist with a microscope, if I see the bone marrow of a patient with a high platelet count, I will look at every megakaryocyte, and if I see one that is looking really, really big and its nucleus is looking really, really complicated, like the two on the right, I will look for a second one. And if I find a second one, I now say, this is highly suspicious of ET. And if I see a third one, that's enough. Just 3 cells, enough for me to say on the aspirate alone, that is diagnostic of ET. The biopsy, on the other hand, which takes a few more days to come through because the processing we have to do is then much easier. But I've already, within about half an hour, if I'm working fast, can give an answer to the clinician saying this is highly likely to be ET. We'll get the biopsy in a few more days. Once you've got the biopsy, you have much more material and it's all in situ, it's in its right position. And now you can see very easily that there are a lot of megakaryocytes and some of them are really, really huge. And here is this string of beads, or that terrible word David used, the staghorn nuclear appearance. I don't like using those words. I prefer to say that there is a large or a giant megakaryocyte with bizarrely hyperlobated nucleus. You know, but you then know, and a hematologist receiving my report knows exactly what I mean. Staghorn, how many staghorns do we see in Australia? Not very many. The staghorn we think about and you think about is a tropical plant that grows in a tree. So I think we have to be very careful. There is a serious message. We do have to be very careful when we use common language to describe complex pathology. And that's why in a pathology report I use the real words. Okay, 3 minutes left. 1 minute left, okay. So myelofibrosis, if I may. Good. Okay. So myelofibrosis, in this, this is where the bone marrow has scarred, and the bone marrow is really struggling to make blood. And we first see evidence of the scarring in the blood film. Firstly, the blood count usually falls. Patients are anemic. The white blood cell count can be very low or can go up and be high. The red blood cells can look strange, and I haven't shown you red blood cells before, but they are crying. They look like teardrops. They're very sad. So teardrop poikilocytes, or teardrop-shaped red blood cells, are a feature on the blood film for patients with myelofibrosis. The image on the right is a very, very sick fibrotic bone marrow. It looks totally disorganised, and that is a word that I use. When you look at the biopsy, it's disorganised. Why have I gone straight to the biopsy and not shown you an aspirate? That is because it's commonly a dry tap. If I put a needle in there and try and suck out or aspirate marrow, it won't come, and that's because these cells are set in this fibrous scarred framework. Some more pictures of very disorganised bone marrow, and the picture on the left showing a vast increase in the number of megakaryocytes, and they all are sitting very closely together. People talk about clusters, and these are really very tight clusters. So if we all gang up together, and they're very close together, very tight clusters, almost forming large sheets of megakaryocytes, and they have peculiar morphology. We then do a special stain to stain the reticulin, or the scar tissue. It's a silver-based stain, and the scar tissue are these black lines. So the brown here is the piece of trabecular or spongy bone I spoke of earlier, and here again. The white is still the fat, and these black lines that are throughout the bone marrow vastly increased in quantity, and this is pathological. Normally you just see, if I haven't shown you a normal, just few fine black threads or strands. This here is vastly increased and wrapping around every single cell. That is scarred bone marrow of myelofibrosis. And I will stop, Anne, because of time being up. And just to show this final slide, I mentioned the bone overgrowth that can occur, the osteo is bone, the osteosclerosis that can occur. And these two images show two things. Firstly is these fine strands of spongy or trabecular bone are vastly thickened. They're wider than I showed you in the normal bone marrow. And you can see that in both the lower magnification image on the left and the higher one on the right. And then as a consequence of that, there is less space, this intertrabecular space, the space between this trabecular bone where the bone marrow production, the blood production is occurring. That is reduced. And on the right at higher power, you can see how little space there is for bone marrow hemopoiesis or blood cell production. So this is quite a serious stage of the disease. The bone is thickened and the bone marrow space has reduced. I'm going to go right to the very end. Some of you will have the benefit of seeing your own bone marrow report. You are entitled to it. You are allowed to see it. It is your body. It is a piece of writing about your bone marrow. What that report should say is about the sample. Was it adequate? Was it a dry tap? Was the biopsy long enough? How many cells were in the bone marrow? Was the number normal? Was the pattern normal? Was there any abnormality in the pattern of that streaming that I showed you with the fibrosis? We should have then comment on each of the cell types, the red blood cell, white blood cell, and platelet-making cells, all of them, to talk about did they look normal or not. And in the MPNs, a key point is about the megakaryocytes. Where were they? Were they in the right place in the bone marrow? Were they sitting next to the bone, which is again a feature of myelofibrosis? Were they in clusters or sheets, or were they in single cells scattered throughout the marrow? And were there any abnormal cells? Were there any leukemic or blast cells? Then the framework, the skeleton of the bone marrow, the bone itself that I just showed you, the scarring, the reticulin, we should be commenting on each of those features. And then giving a diagnosis. Bone marrow shows myeloproliferative neoplasm. The features are most consistent with, or diagnostic of, or highly suspicious or suggestive, depending on our degree of certainty. And we should say essential thrombocythemia or polycythemia vera. It's not always black and white. I've shown you classic examples, but it's not always that easy. You may not have thought that was easy anyway, but it's not always straightforward, and there are distinct overlaps, and David alluded to one of those earlier. So if you end up with your report saying it could be PV, but there are features of ET, that may well be what it looks like. Or there may be one bit of the bone marrow that looks like ET, but there is another bit that is already showing some evidence of transformation to myelofibrosis. We need to say that in the report. And we also should say, if it's a follow-up, has it changed since the previous? For those of you who are seeing a haematologist or another clinician who says you don't need a bone marrow, tell them Wendy says you're wrong. I'm happy to be quoted. I really do believe it's very, very important. As I said, and I am reiterating, it's giving you the baseline. It is giving you as precise a diagnosis according to the WHO criteria, if we can, but giving you a precise diagnosis. It should be used as one of the ways of monitoring treatment. It's not to say you have a bone marrow every time you see a doctor, and I'm sure you don't want one, but there will be specific time points in the treatment monitoring when it should be done. Detect any changes. You can also seek the best opinion. You can ask for a second opinion. I'm very happy to provide a second opinion on the pathology of a bone marrow. I don't charge for it. I do it because I think patients deserve the right answer. I don't always get it right. I try to, but I don't always. But I can certainly give you a considered opinion. If your clinical opinion is not what you want, you're also entitled to change that as well. I'm sure David and Cecily would be happy to have more patients come to Adelaide and Gosford respectively, and Kate will see everyone in Melbourne at the end of today. It is your right. It is your right, and as doctors we should not be arrogant. We should, and you are totally entitled to get the best opinion that you can, because this is your health, it is your body, and you have one chance of life. I've put there research samples, but I'm not going to talk about it. I'm going to stop there.